Our next speaker, who is Dr. ASHU Agarwal, practicing at Perfect Sight Center in east of Kailash, a very prolific surgeon, and he has his own case, interesting case to show.
So I'll be talking about ACL antechamber IOL implantation, and basically this is a difficult situation. I'll start with the step when the rent has occurred and anterior vitrectomy is being done. Pupil constriction is done by pilocarpine and a viscoelastic is being injected. Here I'd like to take a minute that I have a little tip here where I use a dispersive viscoelastic first, followed by a cohesive one like sodium hyaluronate. Then a PI is done by a vitrector, and the sodium hyaluronate is used to form the chamber. In contrast to what most of our colleagues would do, the incision is being enlarged, sizing has been done, and usually the rule is horizontal white to white with the 1 millimeter addition. We should ensure correct orientation of the haptics, and correct orientation also ensures the correct vault, which should be anteriorly in these Kelman multiflex IOLs. You can see the anterior vaulting over here. Then the ACL is being implanted. Here we should ensure that the plane of insertion is more or less parallel to that of the iris. And when we go in, we should ensure that the leading haptic should not engage the pupil and should go and abut in the angle at the scleral spur without encompassing the iris, peripheral iris. So we may at times need to reform the anterior chamber. Again, some viscoelastic is being injected. The chamber is being reformed so as to ensure that the peripheral iris does not get caught up in the leading haptic. Realign, move in. The trailing haptic, the knee is inserted behind the edge of the wound, and the trailing free plate is being inserted in with the Lester's manipulator or a micro hook. That's the IOL in place. Some wound hydration is being done. I often like to suture the wound, but at times I've also left it when the astigmatism was in that axis. I've left it without the suture also, but here in this case it was being sutured. The knot is buried and the AC is being reformed. And at the end, you have a well-positioned IOL. Post-op 1 week pictures. So this is the Kelman multiflex IOL, and here I'd like to make a statement. These ACLs have gone into disrepute over the years, but Kelman works well provided certain basic principles are adhered to. And I'd like to state that it is not the proximity of the lens to the endothelium, rather the pseudo-phacodonesis that is responsible for the endothelial cell loss. So there are certain important considerations. One should adhere to proper technique and indications and ensure a good vitrectomy. There are certain critical issues like correct sizing, correct orientation, and correct powering of the lens. And in fact, if correct size is not available, we should consider other options and not just push in. Because if the size is not right, we should not just aim to push in, we should then opt for other good options available. So again, a few words about the OVD. This is my own tip that I'd like to highlight. I usually prefer an inertial dispersive viscoelastic to coat the endothelium like HPMC. Sometimes I use chondroitin sulfate based like viscoat to protect the endothelium. To protect the corneal endothelium, and then a cohesive viscoelastic like sodium hyaluronate 1.4% is injected, which forms the bulk of the anterior chamber, and it is the soft shell technique. The dispersive coats the endothelium, protecting it, and the cohesive keeps the AC well formed and is very easy to wash out during irrigation and aspiration. It just comes out like a blob. The initial difficulty in my initial years that I faced was that when I'm finally doing the irrigation aspiration, the lens in place, the vitreous would get mixed with the irrigating fluid, and again, while ending the surgery, again a lot of vitreous would come in, and the pupil would get deformed, and I would have had to repeat the vitrectomy. But I realized when I use a cohesive viscoelastic, it just comes out like a blob. The irrigation part is very minimal irrigation aspiration, and really helps in keeping the surgery under control. So important tips are correct sizing, orientation, and avoiding iris tuck. Thank you for a patient hearing. I'd just like to, I have a few seconds left. I'd like to highlight this with a different video. Can I do that, ma'am?
Yes, yes.
Let's share again. Yeah, so same principle that I just like to highlight. Is the video audible?
No, not able to see the video.
Okay, sir, just a second. No, just a second.
What does you want to show in that video?
Just the same principles that, let's see if it does, otherwise I'll just skip it.
I think you're sharing the wrong window. I think stop sharing and share the video player window.
It's not running?
No. I think you're sharing the wrong window. It's showing you the Finder window.
Okay.
Share the video player window, whichever is the software window. So
just 1 second. I'll just open this video.
yeah, first open the video, then share the screen.
Yeah, that's what I do, right? Thanks. Thanks for that.
I think we can take the
Okay, fine.
discussion.
I think let's skip it. Yeah.
Now, is it that you do ACIOS on a regular basis, or this was just one video wanted?
No,
to
no,
show
ma'am. No. In fact, I've tried out everything. I've tried scleral. I've tried glued is a very great technique. But what I realize is that ACIOL1, it works well, provided certain basic criteria are fulfilled. Like we should not just push in the lens for the sake of pushing in a lens. The correct sizing is important. The endothelium should be good. There should be good iris support. Plus, I also believe that the reason for making this video and highlighting this technique is that iris clip lenses, glued IOL, they're great techniques, ma'am, but there's a significant learning curve. So if the case selection is proper, anyone sitting in their own practice without knowing these difficult techniques can do this lens. So that's the reason for highlighting it. And what made things easier for me was that little viscoelastic tip that I realized that about 21 years ago, in 2000, I did it for the first time, when I put in some Helon GV, and I realized that this makes life so simple, because till the moment of placing the ACIOL, if you're going with the correct principles, is not difficult. The difficulty I used to face was when I was finally closing the case, I was doing the irrigation aspiration, the vitreous, whatever it was, even after the vitrectomy, would get mixed with the irrigating fluid, start coming out, the pupil get deformed, and there'll be vitreous in the anterior chamber, and then again it was a mess. So when I realized that I put in Helon, irrigation aspiration is just a little blob that comes out, and minimal hydration of the vitreous occurs, and that really made things easy for me. So there are, in fact, I do it whenever I need to do it. I do it routinely, and this would be a preferred technique provided the basic criteria are being fulfilled.
No, but then you have not measured the AC depth. You haven't.
Ma'am, that was no. This got missed out. No. This got white to white got missed out in this video. That's the reason I was trying to show the second video where the calipers are used to measure the white to white. So that is very important.
And white to white is okay for the ACIOL measurement, and there itself angle to angle and white to white may be different, but the AC depth measurement is not done. And
AC depth measurement on table, you mean?
Yeah, because this is a.
So,
it will be there on the IOL master.
AC depth is usually there even in any ultrasound biometry. We will have it. So of course, this is when I didn't show it in the second video. It would have shown that the contraindications were mentioned, that is inadequate iris support, poor endothelium, pediatric cases, and shallow AC are contraindications to this. So if you don't have these contraindications, in addition to not having a correct size of horizontal white to white +1, then we should not do it. So that's what I keep repeating, that provided these conditions are met, this is a great technique. And for anyone, not for any surgeon who is not familiar with glued or scleral fixated or iris clip, which are which have a certain learning curve.
It makes sense because now our surgical awareness and knowledge of all these things is so refined that we could reconsider it. I do agree with
so I do because ma'am, I've been doing, so this is even today my preferred technique, because one, it's a stressful
but then you
moment.
need to do YAG PIs and all that. See, you're talking on a
Yeah.
podium where many people are hearing. So
Yeah,
we
ma'am. So
should
this
not
I did
convey
a
the wrong message. So I want my experts to also
No,
open.
no,
no,
it's
ma'am,
not
I did a
it's not a wrong
vitrectomy.
message.
I use a vitrector. I use a vitrector to the PI. PI is important. I use a vitrector on the table, or you
Yes.
could do a post. Even if you are not, some people are not happy with the vitrector because it chews away. So sometimes you can do a YAG also, or augment it.
No, YAG is not required. You are doing a surgical iridotomy.
Yeah, that's the best. That's the best. I did it.
For you,
Either you do with a PI, either you do with the vanas or
vitrector. That's beside the point. There are
Yeah.
two things I think which you need to emphasize. One is the 100% requirement of doing a peripheral iridectomy,
Absolutely.
surgical on the table, and the second is to do a good vitrectomy. You need to have a deep chamber, because often people just shove in this lens, and then you can see that half of it is sometimes inside, sometimes outside, and things like that, and there's a pupil capture. So you need to ensure that you have done an adequate vitrectomy and there are no tags and the pupil is not updrawn, etc. And it has been shown in various studies that the Kelman multiplex does not cause endothelial cell loss. If it is properly, if it is properly sized, there is an iridectomy and there is no vitreous in the anterior chamber. So these are prerequisites that you have to do, and you don't place it upside down.
Absolutely. It does not get flipped. So there's another video I have where a flipped lens where the vault is posterior, that can cause havoc. So so basically, again, like Dr. Maipal rightly said, a good vitrectomy, ensuring that there's no pupillary capture. And to enable all this is the tip that I said about trying, and I would request the panel here to try out, use Helon, any brand name for that matter, basically a sodium hyaluronate, and that really helps because the vitreous is not getting mixed with fluid, and it really helps in controlling the situation. You don't have updrawn pupils, you don't have pupillary capture, and it's a very controlled surgery.
Excellent video.
Can I make a comment?
These days when we are constantly talking about iris clip and sleep, you brought back this AIOS. But I think the basic problem would be more of logistics, having a lenses available. For example, I may be wrong. I just saw a glimpse of that label. It was, I think, something like a 16.5 with a 12.5 millimeter diameter. So maybe if you're doing it secondarily, you can measure the white to white, order the particular lens, and the IOL power has to be 1 diopter less than what you had planned for your posterior, in the back fixation. So, but on the table, if you have a complication,
3 diopters, Ramurthy.
No,
This is 116.
No, just 1 minute.
116
Let me just finish. Let me just
the
finish.
normal lenses PCIOL is 119. This is 116.
I think it's at time 114.7 also. So
3
significant.
diopters less you have to go.
No, the 3 diopters, basically it is the difference of the, if you're talking of powering, it's the difference of the A constant. Just subtract the A constant difference from the measured power. That's the rule of thumb. And Dr. Ramurthy rightly pointed out, see, Alcon in USA markets 5 sizes of these lenses, 5 or maybe 6. In India, Aurolab says 3 sizes, but practically we just get 12.5. Unless you get it like in a secondary aisle, secondary aisle you can get it ordered, but off the shelf you get just 12.5. So the number of cases we can do it is very limited, and that's why I always keep repeating.
High myopia, you have to be careful.
We don't just push it in. The sizing is very important, and powering is not so difficult because it's a constant difference from the measured power. And so again, if the weight of the panelists here is there, the companies may be motivated to manufacture various sizes of these lenses, and this can work. I still stand by this lens because in my experience. And so I'd like to highlight that I'm a cornea surgeon, and in my cornea transplant patients where there's no support for the lens, there are many patients that I've put in these lenses in a PK patient, penetrating keratoplasty patient, and they're doing fine. So which shows that the cell, like Dr. Maipal said, the endothelial cell count does not get suffered.
Can I say something?
Yes.
The basic book of intraocular lenses that I read when I was doing my MS, and I don't remember the name, but I'm sure I can find it. There was a very important footnote which was written there about the ACIOLs, that we never consider the movement of the patient when they bend down and what happens to the lenses. And it was clearly mentioned that that is also responsible for the endothelial cell count. So that's one point. The second thing, like Mahipal sir said, that, the AC depth, because we operate so many patients with a very, very shallow angle, and we've explanted so many of these patients, and some part of these lenses definitely are in the angle, and out of the 360-degree angle, if you see the two loop or the plates which do connect with the angle, they're definitely going to cause inflammation, and we've expanded a lot of these lenses. Dr. ASHU sir, I really respect your video and everything, but these are our experiences. So I would like to just say that.
Ragini, again, Ragini.
I want to say something.
Yes.
You're talking of Payman, I think, because we all read that Payman.
Not Payman, there was a book of lenses, only intraocular lenses. I don't remember the name.
So when I was
footnote.
So when I was doing my MS, that time there was a study, a US IOL or some study, and part of it was conducted in Nepal. Dr. Mahipal might remember that, which really put these lenses into disrepute. But the basic problem was sizing, and most of the ACIOLs initially, the manufacturing, the polishing was not good. They were closed loop designs. This is an open loop design. In a closed loop design, it's a one size fits all, which is a wrong concept for this with this kind of ACIOL. So unless we look at it with an open mind, it's not going to be. If we keep getting stuck about 30 years ago, what was done, we'll be stuck there. We have to look at it with an open mind and then go ahead with it.
Shall I make a comment, Chitra?
Yes, yes.
I think we cannot just put ACIOLs into the dustbin. There is a place for ACIOLs. I still put ACIOLs for a very old patient, for example, 75, 80 years old, when I have a PCR or a capsule loss completely, I don't want to put a glued IOL, and I make sure the endothelium is fine. Then all the three golden rules, as Mahipal and ASHU rightly said, take care of the vitreous, take care of the iris, that is iridectomy, and sizing of the lens. And also, I would slightly differ from ASHU, because you're putting the lens vertically.
Yeah.
Okay, always put the lens horizontally or oblique. Because if you try to rotate the lens will probably, otherwise if you put it vertically, you do not know exactly whether it's sitting in the angle.
Yeah.
But if you try to rotate the lens and put it in the horizontal, then you know exactly it is sitting in the angle. Okay, these are all angle supported lenses. Yeah.
So angle is all long. So it's a 360-degree angle, and when when you're tucking it in, so I used to do it horizontally. Yeah, I used to dial it horizontally, but then I felt that it's causing unnecessary trauma in that sulcus area, and I realized although you're right, we measure white to white horizontally. But even what I've realized over the years is that putting it vertically, and now I keep it vertically only, that works very well. If you've sized it well, that 0.25 to 0.5 millimeter is also adjusted.
Absolutely. The problem is when you put vertically, that is one of the loops one of the haptics is going sub-incisionally. Okay? You are not sure whether it is sitting in the angle, that you're not it's not 100% confirmed.
No,
so when you dial it horizontally, then you know exactly the lens is stable there, then you know exactly it is in the angle. And there's no need to put viscoat. There's no need to put viscoat. Just put Hyalon.
No. You're right. No, that is initially, viscoat is only for when the endothelium is, I suspect the endothelium not so good. So I use it as a protective measure. But you're right, even Hyalon alone would be very good for this.
Very good, because you need only a space in the anterior chamber. Yeah.
Mohan, I have a slight disagreement with you. Normally, I do not tend to rotate these lenses because
I don't know.
So if you have to put it in the horizontal, put it in the horizontal from the word go. Or what you are talking about sub-incisional, the simplest trick was we had those limbs forceps at that particular time. You just hold the wound, pull it up, and with a McPherson, just push the lens in and tuck it in. That's it. It goes and sits where exactly it is supposed to be. But if you are free wanting to really dial it, you will end up having problems. So I would suggest that
even
we don't dial it. If you want to put it in the horizontal, go from the horizontal.
So even I don't dial it anymore. I used to. And you rightly said, sir, the knee of the trailing haptic goes in with the McPherson, and the free foot plate. You just take a Lester's manipulator, which we all used to dial, and just tuck it in, and it just snaps into place, because it's a convexity over there. Where else will it go? It's going and meet at the angle. Because there's sclera behind it.
If you have
this is a very controversial topic. The whole time will go on.
Let Ram speak, please.
It was a wonderful.
give Dr. Ramuti a chance.
At the end of the surgery, if you have a round pupil, that itself tells you that the placement of the lens is very good, and there's no tucking of the iris.
That's another sign which in fact, in this short video account, ovalization of the pupil is again
Yes,
something we need to look at. Yeah.
No, that was a wonderful video. But just before we end with the secondary IOLs, one question I will have to ask. If you're going to do a glued IOL instead, would an anterior vitrectomy be enough, or would you think we should actually say that everybody should learn past planar vitrectomy if you want to do a glued IOL?
No, not required.
Not
I think
necessary.
that much is not required.
Don't do that to us.
No, not necessary.
Past planar vitrectomy is not very difficult, especially if it is concerned with the
When
core
I is
vitrectomy,
smiling, when I
but
can
it's
see
not
when I is
required,
smiling.
ma'am.
When I is smiling over there.
I think one thing what ASHU has brought out very nicely is that the vilification of ACIOL has been because of poor technique that we have been doing,
Poor quality
rather than the
IOL,
IOL
poor
itself.
technique, yeah.
So
Poor
now with
technique,
better
poor
vitrectomy cutters available, there's not a bad idea, and especially if it's coming from a person like ASHU, who's a cornea guy, who's most concerned about cornea.
Yeah.
So that reaffirms the faith into the ACIOL, but a proper technique, I think.
That's the
That's
proper technique, proper sizing.
Yeah,
There's no shortcut to that.
Yes.
And only the Kelman multiplex.
Only
Yes.
Kelman.
Multiplex.
The open loop types, not the closed loops.